7, 5, 4, 3, 2, 1. We are live now.
Good evening, everyone. I welcome you all in the another series of ROSA hand surgery webinars. Today's topic is all about scaphoid, not to miss scaphoid fractures and scaphoid non-unions and all about that. And today we have the guest faculty, Dr. Darshan Jain from the Banglore, and from the ROSA faculty, Dr. Rahul Garg, Dr. Amit Mittal, Dr. Aviral Gupta, Dr. Chopra, Surendra Chopra, and Dr. DP Chaudhary. To formally start the proceedings of this webinar from the Rajasthan Orthopedic Surgeons Association, I would like to invite our President-elect, Dr. Jasawant Singh, to start the proceedings of today's webinar. Over to you, Dr. Jasawant.
Hello, thank you, Rahul. Hello, good evening, everyone. I welcome Dr. Darshan as a guest faculty. Hello, can you hear me now?
Yes, sir. Yes.
Yeah.
Thank you very much.
And today's topic is on the scaphoid fractures. It's one of the burning topic, and many of us usually come across this fracture very frequently. And to get the in-depth knowledge about this, we have the Darshan today with us. So I welcome Darshan.
Thank you very much, sir.
As told by the Dr. Rahul and both the Rahuls, that we and Amit, we regularly conduct such webinars regularly in Rajasthan Orthopedic Surgeons, and probably we have conducted highest number of webinars in last 3 or 4 years since the COVID times. So in that series, you are our guest faculty. I welcome you again, and now please deliver your talk.
Thank you, Dr. Jaswant. So I also welcome the President of Jaipur Hand Surgery Association, Dr. Purnima ma'am. She is a very senior faculty from Jaipur. And for today's webinar, our moderator is Dr. Amit Vyas, who is the treasurer of the ROSA. So now to start today's webinar, over to you, Dr. Amit. Please start the proceedings.
Yes, sir. Thank you, sir. Good evening, all. First of all, scaphoid fracture is most common carpal bone fractures, and it is encountered in day-to-day practice of all orthopedic surgeons. And the most important thing to remember about the scaphoid fracture is that there should be high index of suspicion about the scaphoid injury. Otherwise, it is easily missed, and then it leads to scaphoid non-union. And if scaphoid non-union is not treated, it leads to scaphoid non-union advanced collapse. So, ROSA office bearer gave me this opportunity to conduct this webinar on scaphoid fracture. First of all, I would like to introduce our guest faculty, Dr. Darshan Jain. Dr. Darshan Jain is senior consultant hand surgery. He's located at Banglore in the Apollo Hospital. He has good academic career. After finishing his MS Orthopedics, he did basic degree in hand surgery, FNB hand and microsurgery. Then after that, he has done a fellowship at National Institute of Singapore and Paris, and also in London for the shoulder and elbow fellowship. And he has 15 PubMed articles he has published. And one of the most important aspect of his career that he has a good name in wrist arthroscopy, and he conducts cadaveric wrist arthroscopy courses in every year in Ramaiah Medical College. Welcome, Dr. Darshan. Then with us, we have our President-elect, Dr. Jasawant Singh, sir. He is also well-renowned orthopedic surgeon, and he has his good name in hand surgery also. He's located at Katta. And then Dr. Rahul Katta sir, he's honorary secretary of Rajasthan Orthopedic Surgeons Association. He is located at Jaipur. And Purnima Patni madam, he's president of Jaipur Hand Surgery Association, and he's retired head of the department of and head of the unit of hand surgery at SMS Medical College. Presently, he is working at Surya Hospital, Jaipur. And with us, we have ROSA faculty, Dr. Rahul Garg. Dr. Rahul Garg is senior consultant in orthopedic surgery at Jodhpur. And Dr. Surendra Chopra, he is associate professor at SP Medical College, Bikaner. He is senior orthopedic surgeon. And Dr. Aviral Gupta, he is consultant hand surgeon at Santokba Durlabji Medical Hospital, and he is senior consultant hand surgery in Jaipur. So with this introduction, I would like to invite Dr. Darshan Jain to start his lecture first about the acute scaphoid fracture, then case-based discussion on the chronic means non-unions of scaphoid. Thank you, Darshan.
Good evening, everyone. Thank you. Thank you, Amit, and thank you, Rajasthan Orthopedic Association, for providing this opportunity to present my work. I was surprised to know that so many of them are attending the webinars this thing, because we thought it was only a time where
just to interrupt in between, Dr. Darshan, right now more than 500 are live audience with you.
Great, sir. You guys are doing a great job. Now this stimulates us also to do something in Karnataka as well now. So, sharing my first presentation on the scaphoid fracture.
I switched off my video.
So basically, this talk is on decision making in acute scaphoid fractures. So we all, first thing is, most commonly either miss it, or the fear of scaphoid fracture is so high due to various reasons. Scaphoid fractures account almost 60 to 70% of the carpal fractures, and are second in frequency of wrist fractures only to distal radius. So looking at the classification, there are various classifications either by location or by orientation. Orientation sometimes even it also dictates the stability of the fracture. Why location is critical? Because this also dictates the union status of these fractures, or the possible chances of non-union we get to know. That is, more proximal the fracture is, the difficult will be to the union status, whereas more distal it is, better the healing status. So waist is the mid portion of the waist fracture is the most common fracture which we come across routinely. Next, talking about the classification by orientation, it could be either transverse, horizontal, or oblique, or the vertical, horizontal, oblique, or the vertical fractures. These vertical fractures are the fractures which have been very difficult to manage because the shear flow forces are high, whereas transverse fractures are much better. Horizontal, oblique also can be relatively better. Another classification is by Herbert's, which is basically, as I told, stability. Based on the stability, it is classified, whether it is stable acute fractures or unstable acute fractures. And further classification goes into C and D, whereas it's delayed union and established non-union. So what are the potentials for healing on means what is the healing depends on? Basically, it finally dictates what is the fracture location, vascularity, and stability. So these three things govern the union status of the uniting nature of the fracture. What do we fear about? Again, that is non-union. Next is non-union. What is the percentage? Non-union occurs in almost about 10% to 15% of all scaphoid fractures. Why is this risk of non-union so high in these, and what are with the risk increases? The delay of treatment for more than 4 weeks, proximal pole fractures, fracture displacement greater than 1 millimeter, osteonecrosis, and tobacco use. All these are a predisposition or the risk of non-union increases. Next, what else we can see whenever there's a scaphoid fractures? That is a disc deformity or the dorsal intercalated segmental instability. Whenever the SL angle is more than 60 degrees and the capitolunate angle is more than 15 degrees. That is one of them. And also there is a problem of humpback deformity. Patient, we might see sometimes the scaphoid fracture union, it shows beautiful union at the scan, but still the patient persists to have pain in the wrist. So that could be because of the humpback deformity or the intrascaphoid angle, which is more than 45 degrees. Normally it should be within 24 degrees. The non-union rates, what are the non-union rates when you talk about undisplaced waist fractures treated with casting alone has got almost, in spite of this thing, 5% to 12% non-union rates, and displaced scaphoid fractures treated non-operatively, almost 50% scaphoid non-union rates. A lot of these statistics are mainly from the European literature, but this is where they treat aggressively. And what is a non-union? The rate of the scaphoid non-union ranges from 4% to 50%, depending on the fracture type, displacement, and treatment modality. Increased rates of non-unions are seen in non-displaced fractures, missed or managed without immobilization, and displaced fractures larger than 1 millimeter displacement, proximal pole fractures, early signs of osteonecrosis, and humpback deformity, and a vertical oblique fractures. What do these examination findings typically show us? Any wrist injury, a patient comes with a swelling, you have to suspect scaphoid fractures, because normally any fall on outstretched hand without an obvious fracture which is seen, if it is not seen in the distal radius fracture is not seen in X-ray, that means you have to have a high element of suspicion. And this swelling can be noted only by comparing with the opposite side, because a lot of times we miss out comparing them. That is where the fracture we tend to miss. And tenderness, where exactly at the tuberosity or the anatomic snuff box or the proximal pole of the scaphoid. These are the typical clinical examination findings which we should try to elicit. Next comes the X-ray. What are the X-rays we see? So typically we take PA view and lateral view. But however, we should not always, whenever you have doubting, you take another couple of views extra, that is PA view with ulnar deviation, 45 degrees pronation view, and 45 supination view. Because of the twisted profile of the scaphoid, we generally tend to miss these fractures. What is the incidence of these fractures? Almost waist is 40%, proximal pole 20%, tuberosity is 10%. Up to 25% of the scaphoid fractures are not visible on initial radiographs. This is really an alarming thing. We should always, as I told, the element of doubt should be very high. And failure to treat these stable fractures within 4 weeks increases the non-union rates. MRI is the best to determine whether there is an occult scaphoid fracture. The specificity is almost 90% and sensitivity is anywhere between 90 to 100%. I'll just show some of these cases like simple fractures and a scaphoid waist fracture. So this gentleman has a fracture around the scaphoid waist. You can see now it's undisplaced. Clinically, typically he had a tenderness there, undisplaced. Day 15, you can see the fracture line is more evident here, whereas initially it was not so obvious. 8 weeks down, managed totally conservatively with this thing, completely healed fracture with a scaphoid cast. So aggressive management, that is aggressive conservative management proposed by Dr. Joseph Dias et al. Is what we commonly this thing. But to do this aggressive management, we have to be more cautious. That is, we have to take all 5 possible views of X-rays we have to take. If you cannot, then you'll have to repeat the patient sometimes, if not an acute setting, again call the patient after 2 weeks, initially manage with a thumb spica cast or a splint, and then call him after 2 weeks, repeat the X-rays. If at all, if patient is more doubtful and he is inquisitive to know more, there's no harm in doing an MRI straight away in the first time when you have a doubt, because that shows the fracture line much better. So Joseph Dias et al. Is the one who propagated this aggressive conservative management. That means where all undisplaced fractures or a displacement less than 1 millimeter displacement, he suggested to manage it conservatively with a cast and repeat X-ray after 6 weeks. Or if you have a doubt, you can even do a CT scan to confirm the union status. The healing rate of an undisplaced scaphoid fracture with a cast immobilization is almost 88% to 95%, provided the treatment is started within 3 weeks. So this is again important. How long can we wait to start? That is 3 weeks undisplaced, a very good role and excellent union rates you can achieve. Operative versus conservative. What is the union rates and when is the early? So operative chances doesn't mean always it heals well. It is the early return to work is most commonly seen with the operative treatment, but also has a higher complication rate. Conservative, this thing we could manage with a short arm or the long arm cast. And next is what is the commonly preferred? We usually prefer short arm cast to include thumb or not. I generally include the thumb to prevent further displacement. But there are a lot of centers in Europe where we see they don't include, they just put a short arm cast. And what is the duration? Typically a waist fracture, around 6 to 8 weeks of immobilization is recommended. So this is a general algorithm when you see scaphoid waist fracture. When you have a suspected undisplaced scaphoid fracture and clinical and radiological evaluation and below thumb spica cast for 6 weeks if you have, re-evaluate after 6 weeks. That is if your clinical evaluation goes with anatomical snuff box tenderness or if you can see a bridging fracture gap. And if there is a tenderness and a fracture gap of more than 2 millimeters, then it is always worthwhile fixing percutaneous or open fixation. And again, assessment after 3 weeks. If you have an element of doubt, even with an X-ray, then it's always advisable to get a CT scan. So less than 2 millimeters, continue the cast. More than 2 millimeter gap, percutaneous fixation is best. And clinical examination gives us more information. As soon as we take off, look for the tenderness in the scaphoid anatomical snuff box. Next is the decision making. So what do we do when different areas of fracture? Distal tubercle fracture, again short arm cast 6 to 8 weeks undisplaced. Distal third fracture or incomplete fracture, again 6 to 8 weeks. Waist, a short thumb spica cast. Some people even fix mini open fixation, but I would always try to fix with, if it's undisplaced, a short thumb spica cast. Proximal pole fractures, non-displaced, always fix. Proximal fracture, always fix, especially with a screw fixation. That is the recommended because there's a very high chance of non-union. So unstable fracture, when do you call it as unstable? When there is a displacement of more than 1 millimeter, lateral intrascaphoid angle of more than 35 degree, bone loss or comminution, and perilunate fracture dislocation, or a disc deformity of more than 60 degrees and capitolunate angle of more than 15 degrees. So these are the ones which we always tend to fix the fractures, unstable situations. Next, when talking about the fixation, there are two ways, whether you percutaneous fixation or the open fixation. I'll show a few photos on the slides about the open fixation. I'll also show about the percutaneous fixation, a video technique. The most important, whether you fix percutaneously or open, what is the trajectory we want to take? That is very critical. So the most ideal trajectory is the green line. That is what is the ideal trajectory what we want. But whenever on this area, the tubercle of the trapezium tubercle is which obstructs to gain access to this level. So it might be difficult. The next point which also determines the trajectory is the orientation of the fracture. In this situation, again, waistline, would be the ideal one, the green line. But if at all a proximal pole fracture is there, a short screw is also sufficient, provided it is perpendicular to the fracture orientation. So what is the starting point? Next is whenever we are seeing on a C-arm, the lateral 1/3 and the middle 1/3 junction is the usual ideal starting point to start the scaphoid guide wire. So what is the position we use? We always try to use a block like this or the folded sheets and extend the wrist from the volar side. So that opens up a little bit of the scaphoid tuberosity. That would be the ideal starting point, because this is what I was telling, if you keep it straight, this tuberosity comes in way. So you have to open a mini open here and then try to pass this. This is the true axis and this is the trajectory which generally we pass the scaphoid screws. What are the pearls and pitfalls? Place the guide wire as centrally as possible in the scaphoid and always consider using an anti-rotation wire. Common errors is using a screw that is too long or too small also. So what we should, once we measure it, we have to subtract at least 4 mm from the measured distance, and a common screw length for an adult is generally a 20 mm. So anywhere you're trying to shoot about 20 mm, if you measure it, that means something could be wrong. You have to recheck it, confirm it. And do not ream past the far cortex or else you will have instability again. So if a feeling of lot of resistance, especially when they're reaming over the wire, stop and look, because the wire might be bent or even broke, or the drill bit might have been broken. So this is quite often when you use, especially since this has got a very thin drill bit, and you could always break the drill bit there. And the other thing is beware of the hoop stresses. Use countersinking to avoid excessive hoop stress that can fracture the near fragment. And consider using the joystick to gain reduction. There are various maneuvers to do this reduction. I'll be just speaking in the live in the video session of that. If needed, you can reduce the pin, the lunate in neutral position. This is a very interesting technique so that you prevent out of dizzy and also aids in control of the proximal fragment. Consider a supplemental fixation for more stability if you want. What are the approach? Volar approach or the dorsal approach? I'll be showing the volar approach. This is a typical distal volar extended Henry's approach that is most commonly used for the distal pole fracture or even humpback deformity if the patient has, and preferred for waist and the distal fractures, preserves the dorsal blood supply. This is a skin incision. That's an extended Henry's incision or the lazy J incision. Once you do that, radioscaphocapitate ligament is seen and the fracture is typically behind this. So this is the ligament which we have to be careful, because we will have to divide if we have to go to the waist level, but we'll have to repair it adequately or else you'll have instability in the wrist joint. So this is skin incision. That's the FCR tendon, the white structure there, then the ligament there. So you divide the ligament and then you approach the fracture site there. That will be the proximal pole and the distal pole. Once you see that, you can open up the fracture site there. So this is opening up of is very critical, because the scaphoid distal pole tends to flex over itself, forming a deformity. So screw fixation. This is a typical percutaneous screw fixation. What we do, a case pre-op. This is the X-ray waist fracture. That's the entry point what we choose. So this, we already discussed about this. Extended wrist position, percutaneous screw fixation. See in all the views, PA, oblique, lateral views, 8 weeks, good union status. So conclusion is this: study the X-rays properly. Do not hesitate to get an MRI if required to confirm the fracture. CT is useful to check the displacement and the union status, not to identify a fracture. Aggressive conservative management is the most common preferred. Be versed with both the volar and the dorsal approach. I'll just show you a video of the percutaneous fixation. So this is an individual with a scaphoid fracture presented almost 3 weeks after the injury. Initially, it looked like first it was, these are the older X-rays, but later on it showed a gross displacement in oblique views. So this is an important tip. Why I'm showing the guide wires straight, because as soon as we drape and check, we have to check the guide wires. This is very critical. Your nurse will not know whether these guide wires will be passing through the screws, because this typical procedure takes not more than 15 minutes. But you can get badly stuck inside the OT, provided if you don't check these things. First is check the guide wires, because your vendor might not have given a proper guide wire, or he might have given a used ones like this wires. I typically showed specifically because this was somebody had used and already there was a cut mark. So there's a high chance that the guide wire can break inside. This was also used and multiple reamings were done. So this should not be used. So you have to check whether it goes both through the drill bit and the screw as well, and as the screwdriver as well. All 3 points These are the ways, because a lot of times these drill bits are so thin, the cannulated drill bit, either the bone must be blocking that, or even sometimes a broken guide wire must have already been left. So please check this before we venture on, or else you'll have problems while managing that. Next is, what is always the problem? What we find is the screw length also is sometimes an issue, if at all, for a beginner especially. So as I told, always try to get a 20 millimeter minimum size. Whenever that size exceeds that, you need to check. So how will we get a rough estimate of fixation even before measuring it? So this is what a cadaveric study which I did at Ramaya, because useful of anthropometrics. So just like whenever we are doing all these scaphoid fractures, or we typically extrapolated this orthopedic knowledge into these, because whenever we want to do a tibia nailing, we tend to see what is the tentative length of the nail of the tibia or the femur. So I did this cadaveric study wherein we assessed the length of the scaphoid with the phalanx, and that showed that the middle phalanx. So this was the cadaveric dissection. These are the soft cadavers, fresh frozen cadavers. This is a scaphoid length, and these are the lengths of the middle phalanx of the index, middle finger, ring finger, and little finger. So size match was quite consistent. The length of the scaphoid matched with the length of the ring finger, middle phalanx. So this is what is so coincident. So whenever you do an X-ray in the PAC system, if you take a PA view of the wrist, sometimes they also include the hand as well, which is not required, but they might. So you measure the length of the phalanx, because this is a straight bone, it's easy to measure. This measurement will be the length of the scaphoid. So you can subtract 4 to 5 millimeter from that and try to use that for the fixation. So this is how typical position user, I use a tourniquet. This is what I do generally. I try to put a wire, neutral wire, so that I could correct the disc deformity of the lunate before I tried. That also gives me a very good control of the proximal poles. That was basically an indirect reduction. So I pass a K wire across the radius to the lunate and stabilize, check in the lateral view as well. And this is how I mark the entry points. That is 2 views, PA and lateral views. This will be the axis of the AP view. This is the axis of the scaphoid, and in the lateral view, this will be the axis. So that gives me the direction orientation. So you can use for percutaneous, you can use a 16 gauge needle. This needle will not be available in the usual set, so it could be with the urologist where they use. Don't use 18 gauge, your guide wire will not go through that. So you can make a small percutaneous incision, then you pass that guide wire, check it in all the views. So once you do that, you could use a depth gauge measuring device, or you could use another equal size K wire and measure it and check the wire. Next is you have to use a cannulated drill bit. So this one you could either use the drill bit. A lot of them are self-tapping. You may not require this as well, but I find because a young individual, a good bone stock, so I use this cannulated drill bit. Be careful, don't try to toggle your drill bit because it can break again, which is possible. And don't apply too much of force. So once you drill that, you check the screw length. There are various types of screws available in the market, but always try to use 2.4 mm. And Indian made screws have one of the issue is the shaft diameter is quite thick. So you have to be careful if at all using, whereas some of the companies are only available, which gives a good shaft diameter. So 2.4 mm. There are the screws which are available short thread and long thread. You could use, typically I use a short thread unless required a long one. So this is the headless screws of the Synthes, which is shown there. So you should note these things. The minute you start this thing, there are 3 lines, green, yellow, and red. This is very important to note that, because as you drive the screwdriver slowly, you can see that once you take a closer look of that, you can see this is getting buried there. So once it stops at the red level, that is where you should see that the screw is countersunk and you have to stop there. So you take out those guide wires from all the angles, from both the lunate and this thing, do a fluoroscopy. You could do a continuous fluoros and check it whether the position, whether the reduction is good and whether the screw length is accurate. This is very critical because a lot of times you might feel some view, you might the screw might be adequate, but later on you might find that this is what is projecting somewhere. So this is very critical to check that. And while passing the drill bit also, you could take a couple of views to assess the position of the screw. So this is the post-op, immediate post-op views of the scaphoid fracture fixation screw. So this is another case, a small incision less than quite displaced. So even though it looks so much displaced, it can be close reduced. This patient was almost 4 weeks, but still we managed to close reduce it by basically the technique which we use to stabilize the lunate, correct the DESI deformity, then stabilize that, then percutaneously fix it. So this is a well-reduced scaphoid fracture. You can see bang in the middle. And you can note this because the fracture was, I have taken off the small part of the trapezium here as well. So that gives me better access towards the better orientation. This I don't do it routinely, but sometimes in this fracture, because it was a bit delayed, I had to resort to this. So this is what is about the scaphoid, acute scaphoid fractures. Amit, do you want to take questions now and go for, or do I finish the non-union as well, or should we wait? What is the?
Yeah, better we will take question for acute scaphoid fracture.
Yes.
So, wonderful talk, Darshan. First of all, I would like to ask one question.
Yes.
After doing percutaneous screw fixation, how much immobilization you will do?
Usually, if I get a very good reduction, I don't immobilize more than 2 to 3 weeks. That's it. And so many times I use a thumb spica splint itself. I don't even put a cast. Yeah.
Okay.
If I'm convinced with my reduction is good.
And second point, as you told that you are fixing by the radiolunate wire.
Yeah.
And what I remember that whenever we are passing the guide wire, we do extreme dorsiflexion of the wrist. So does it interfere because you have passed?
Yeah. So this extreme dorsiflexion is not required. First thing. I don't use, initially I used to do like this. I used to struggle with this. I used to do extreme dorsiflexion and never used to do radiolunate. So basically I could never get the control of the proximal fragment. I always used to struggle. I used to feel when I'm keeping in the extreme dorsiflexion, it is reduced. The minute I turn, my assistant turns, the reduction is lost. So by doing this wire, I don't do extreme dorsiflexion. I use a small roll sheet. You could see that it was not extremely in the image. It was a very small one. So many times I don't even use that also. Slide with the hand itself. With the other hand, I use it and put a K wire. The distal guide wire. So that gives a lot of this thing. It's very helpful. I struggled initially to get these because I was wondering even such displaced now, even grossly displaced fractures with this technique, I'm able to reduce it. I don't have to open it.
So, were you able to do some dorsiflexion after putting radiolunate wire?
The dorsiflexion happens at the fracture site, not at the wrist.
Okay.
So that's where I can control the distal component by dorsiflexion. So that will help me in reduction again. Or else if I do just dorsiflexion, entire wrist tends to dorsiflex again. So I could never reduce it. Whereas here, this one holds the proximal fragment. My dorsiflexion manipulates the distal fragment.
Okay. Any other question from the
Dr. Darshan? What will be the physiotherapy protocol after 3 weeks or 4 weeks?
This thing say you gentle mobilization, because percutaneous fixation straight away 2 weeks gentle mobilization with splint itself, and after 4 weeks we start the strength means gripping exercises we start, and by 6 weeks we could even do a X-ray and check it if it is healing. Then we can even start forearm strengthening exercises and dart throwing movement exercises.
Hello, Dr.
First X-ray. First X-ray is after 6 weeks.
Yes, sir.
Stop. Okay.
Yes, Dr. Darshan. I wanted to ask that sometimes we get fractures which have not been attended to for 4 to 6 weeks. So they are neither acute nor they are we can say that they are non-union. So how do you approach these fractures?
Okay. See, actually, this one I'm going to speak in next talk, but anyhow, I will answer this thing. The minute it is undisplaced fracture, even if it is 1 year, you can just fix only percutaneous screw. You don't have to do bone grafting. Provided that is undisplaced and there are not cyst formation at the fracture site. There is enough literature or publications on this to support it. But if it is displaced, then you have to treat this as a non-union and put a bone graft. There should not be no cyst, no displacement.
So, Dr. Darshan,
Yes.
how you put screw? Is it always from distal to proximal, or in specific fractures, fracture pattern, you put it also proximal to distal?
The proximal to distal, I usually use for proximal pole fractures.
Proximal
Pole fractures, yeah. And honestly speaking, even waist fractures, it doesn't make much difference, because a lot of nowadays we even put a scopy assisted reduction also we do. We could put from the same port, we can put it. So, but standard teaching is waist fracture, distal fractures, volar approach, and proximal pole, dorsal approach.
So how many times you require excision of trapezium? Because most of the time I find, hello Darshan?
Yes, sir. Tell me, sir.
Most of the time I find the just excision of a small piece of trapezium is mostly required through the volar approach, because otherwise you don't get the central center fixation.
Yes, sir. So you
especially just you require just excision most of the time I find.
Yes, sir. Either you do that a small nibbler you can do, or even you can cut the ligament, the scaphotrapezial ligament at that. You just cut that ligament transversely. Then you get access for you use a drill sleeve or that 16 gauge needle. You can go further a little bit. You will get access much more.
Okay.
But there's no harm in excising if you are comfortable, because that gives much more really vertical approach.
The other thing is sometimes, most of the time you use this radial unit wire.
Yes,
that's
sir.
why the wrist it gets stabilized and
Yes,
you get the reduction.
Yes, sir.
Otherwise, you just pass a wire from proximal pole to the distal and let it come out through the distal, and then do the distal to proximal screwing.
Yes, sir. Possible. Yeah. Yes, sir. Yes, sir. We have done earlier, you used to do that, but now this thing, that is also, finally you'll get the access, no problem.
Okay.
Our delegates, what will be period of immobilization if you are doing conservative treatment for the scaphoid, acute scaphoid fracture?
Conservative acute scaphoid waist level, I will usually 6 weeks of this thing, cast immobilization. Distal pole, maybe 4 weeks, but definitely around 6 weeks is the usual time. I will not try to this thing. Proximal pole, no role for conservative treatment.
Tubercle fractures?
Tubercle fracture, 4 to 6 weeks is sufficient.
Sometimes you get painful distal tubercle fractures.
You'll have to assess them and excise, because a lot of these things will become quite this thing non-union also can go, because the patient tends to ignore, they come present late. So if at all it has become a mass there, separate ossification like thing, it might be worthwhile if a distal pole, that part of tubercle to be excised as well. Or a short steroid injection also can do.
Which one is preferred? Kenacort or, I mean, triamcinolone or
Tricot. Tricot.
So, Dr. Darshan, how you assess your fracture union? Is it always by means of X-rays, or you to CT?
Always X-ray, rarely CT.
Rarely CT.
MRI more commonly.
No, union CT only, sir. Union status
Okay,
only
union
by
for union status CT.
Union, yes, sir. Union status.
Yeah, sometimes to diagnose, we need to have an MRI because X-ray.
First time, yes, sir. First time, if you have a doubt, if it within 2 weeks, if they come and you still have a doubt, better to do MRI.
MRI even can diagnose on first day only, no?
Yeah, first day, and even associated ligament injuries or anything, that also. Basically, it will tell us about the bone contusion. So the edema it picks up, that will be very helpful to diagnose.
Yes, if no other question, Darshan, can you continue with your case discussion on?
Sure. So this is a complex case. I mean, it's combination of various types of scaphoid non-union. Actually, we tend to see more of scaphoid non-unions than acute fractures also here, because very few of them really come at the acute situation, or a lot of them are managed by already by other orthopedics colleagues of ours. So acute fractures, only when it goes into non-union or associated ligament injuries or proximal pole fractures or re-surgeries, these are the ones which we more often see here. So this is a 25-year-old male with 2 months post-injury, and his pre-op X-ray shows fracture lines like this. What will be the plan of approach, or generally?
At 2 months, huh?
Yeah.
I would like to go for CT of wrist.
Okay.
To see any cavitation formation.
Okay. So actually, in this case, we did 2 months. This thing CT I could not, because he had clinically he had tenderness, snuff box tenderness was there, and then instead of a CT, we decided to go with the arthroscope. We checked with the union status. So we put a scope there. We found the non-union site was still visible. Clinically, he had tenderness. So we did this thing. So either way is fine. If we can do a CT scan, it's good. Or because in his X-rays, this was the X-ray at 2 months duration. So that prompted us because of his pain status as well. So we did a percutaneous screw fixation. These are the arthroscope portals, which we could see from the scaphoid non-union side. So either of them is good. This is what was the status of union at the 8 weeks duration. Any comments?
Does the initial gap troubles you in the immediate post-op?
Immediate, no. Means immediate post-op, no, because that's where sometimes I'm very confident with the scope. Earlier, I never used to. I also used to do CT and this thing. This just gives me 2 minutes. This thing, I put a scope, check after fixing it. Also, I put a scope and check whether the compression is there or not. So especially these type of fractures, if at all I have a doubt, or else if I feel the feel is good, I just accept that. So this is what was one of the when I was searching like this, like similar question, Doctor, I think Aviral asked me about this thing. When do you consider screw fixation, or when they come late? Because 90% of the fractures they don't come on the day one. They come only after 2 weeks or 1 month or even late. So you can consider screw fixation only in this thing, in these situations. Delay in treatment less than 1 year from injury, undisplaced as demonstrated, as where Amit was telling me, the CT scan, undisplaced as demonstrated on CT scan, no humpback deformity, less than 1 millimeter displacement, a stable fracture fixation, that is a waist fracture, no fracture site, motion on live fluoroscopy. This is another factor which you could use. No signs of avascularity if you have done an MRI and there's no signs of avascularity. But however, this point is nowadays questionable. And minimal to no bone resorption, less than 1 millimeter to 2 millimeter, or sclerosis less than 1 millimeter. So this is where we use percutaneous fixation even if it is late. And pre-op CT can give us more information on the fracture orientation. A carpal alignment or a scaphoid deformity to be corrected by using Vyas as joystick. Adequate preparation of the non-union site if at all you feel that's not gone into non-union, and central placement of screws. Supplemental Vyas can be used as scaphocapitate or radiolunate for unstable non-unions. That was for the first case, what I thought, because I read of when we were doing about late presentations. So this is case 2. Or you want to discuss anything on case 1, or shall we go ahead with the case 2?
Any other question from faculty? And okay, carry on.
Okay. 30-year-old male on cast from past 3 months following injury on outstretched hand. So he was already on cast, and this is a situation with a cast on 3 months. Proximal pole fracture. What will be our options?
So probably it is means it is proximal pole scaphoid fractures, and either it is in cast, so I'm able to see the more means whitish shadow in the proximal pole.
Yeah.
And so I would like to confirm it that something is happening, means non-union. So probably I would go for MRI.
Well, the role of MRI next is like, with how much importance will we give MRI for the role of MRI in these situations? Because non-union ends are resolved here, non-union is proved. Now you want to look for the vascularity.
Vascularity of the proximal.
Okay, how much importance would you like to give for the vascularity of the proximal pole?
To be frank, MRI will give you the clue that the proximal pole is going to avascular or not. Otherwise, we will confirm it during intraoperative period.
Okay. Nowadays, a lot of literature, because even I think I have done an MRI for this patient, or it was this thing. MRI next is whether only MRI or contrast MRI. If you're really looking at vascularity, what would you want to do?
Contrast MRI would be better, I think.
Yeah, contrast MRI definitely shows the vascularity, this thing. So this is what is the MRI showed, the proximal pole avascularity. So before we go into problems in managing this case, but there are good number of papers which have come up from past 4 years telling that MRI significance of means MRI has got no role in dictating the treatment of line. It might tell you avascular or non-vascular, but it really doesn't dictate, because there are enough number of papers nowadays published. A simple bone grafting, you don't need a vascularized stuff. A simple bone grafting is good enough to manage these situations. There are a lot of literature on this. I don't know how many of you have read or agree with this, or have you come across these type of situations or papers where there are a lot of papers coming on this. Looking at the problems in managing these fractures. So first is vascularity, where you guys were telling. So which I have told now that it is really means not. I really don't give so much value nowadays to this MRI about the vascularity. I don't judge them with that. What graft to use? Next is whether you want to use vascularized graft. Basically, if you have that issue, whether 1-2 intercalated or you want to use a graft from the iliac crest. What are the fixation options? Because considering that fragment is so small, what will be on these headings? What will be your or the faculty, other faculties options on managing this on these 3 headings?
Vascular graft will be better in this case, in this condition. One, and fixation option, I think even a K-wire or a thin guided, a smooth K-wire, 1 or 2 K-wires would hold it in the place along with the graft. I think that would be enough rather than putting a screw and as the fragment is quite thin or small, it may in fact fracture or it may give way. So I feel 1 or 2 guide wires would be enough to hold it.
What will be the size of K wires you would want to think of?
0.8, 0.5 or 0.8.
Okay, so vascularity, different opinion. Graft, vascularized graft. So fixation options, even either of them. Any other, if at all you are keen on putting screws, anything else you want to, like if you want to put a screw itself, do you have any preference in this, or you will never touch screw? I would or rather be happy with only K wires. Or even is there any configuration which you follow whenever you're doing for K wires of these type of fractures?
If less than the profile, if less than 2.4 mm available, then I think we can opt for a lesser profile screw.
Okay. You know any company who's providing less than that size?
I have no.
Okay. Okay. Anybody else?
Personally, I will go for bone grafting and K-wire fixation only.
Any configuration in K wires?
1.2 mm.
No, what is the configuration? Is there any specific configuration you want to? Means there are various. A lot of them just pass only from these proximal pole to distal pole. Or do you have anything else additional K wires you want to use, or only that you want to stick?
No, only 2 K wires.
Okay.
So, I may put in a radial lunate wire also, just to have a better stability of the proximal fragment.
Okay, so these type of fractures, your K-wires can be done, but one thing is we commonly, whenever we are doing such a thing, your configuration, usually you have to put from distal pole to the, from distal pole to proximal pole to the lunate, not radial lunate wires. That is one thing which is quite often recommended. Scaphoid lunate wire. So that is one recommendation, because you want the entire unit to act as a single unit, because the distal pole again at that fracture site, it again starts toggling. So if you put that wire, and along with that you could complement with scaphoid capitate wire as well. That is one thing. So it acts as a triangle wherein it acts as a single unit. Even if the wrist moves inside, it will be a very stable configuration. So that is one thing. Second thing is, there are 1.8 mm K wires. KLS Martin has got, that's the only company in India which is available, which has got 1.8 K wires, headless screws, not this thing. So we could use that as well. So here I was also earlier used to do a lot of vascularized bone grafts. So use this 1-2 intercompartmental knuckle, and this is the 1.8 K wire, means KLS headless screws which I've used. So that went on to a good union, 12 weeks post-op. So tips: use vascularized for proximal pole. Smaller screw, 1.8 are available. KYS is an option. And vascularized, this is what I was telling, non-vascularized. Nowadays, these type of proximal pole fractures also, I don't open it. I do arthroscopic, put only bone grafts and put multiple thin KYS. So they do quite well. Even if the proximal pole shows AVN, I have got a good series of now proximal pole AVN managed with only arthroscopic bone grafting. Any questions on that, or should we go to the third case?
Arthroscopic, arthroscopic assisted bone grafting, and
Yes,
then
sir.
fixation also arthroscopic assisted or under CM?
Scopy assisted with the CM. It's percutaneous fixation, not open.
percutaneous.
It's all percutaneous.
Okay. All percutaneous.
Fixation.
Okay.
Yes, sir.
So, do you excise your non-union by arthroscopically?
Yes. So you use either shavers and even curettes. You can do a good job with that, and pack it with a cancellous bone graft and then percutaneous. If you want, I can show a video also on that if at all you have finally time permits.
Yes.
So, Dr. Darshan, in this particular case, you waited for 3 months. So, what is how long you would
I
wait?
did not wait. He came, but ideally 3 months is okay. 12 weeks is of immobilization is reasonable for proximal pole. It's longer duration, but that is what is a recommended one. Maybe in this case, it was much more obvious earlier itself, because the kind of resorption what we see, what I saw in this, maybe I would have taken a call bit early itself. Because proximal pole, I hardly put a cast. I always fix proximal pole fractures.
Do you routinely do contrast MRIs, or have you stopped doing?
No, I don't do MRIs now, but they enter my clinic with MRI films. So it's all referred. When they are referred, it is already thought that, okay, he would require, and that is still the concept. I stopped believing in that avascularity of this thing MRI, unless they are very old non-unions, like 5 years, this thing. More than the MRI, I don't try to, I counsel them that chances of non-union, if it is so old, 5 years, 7 years, non-union, young chaps, like 25 years, 27-year-old guys, they would have had non-unions. So I caution them that non-union is a little bit of higher status because the time duration lag, but I go ahead and fix it. Any questions, or should we go to third case?
I think we can proceed.
Okay, sir.
Yes. Yeah.
There's a 27-year-old male, injury to the wrist 15 months back, not taken treatment, now has pain. So this is how 15 months, you can see in this view, it's not at all visible, but whereas here you can see there is loss, resorption and sclerosis at the end of this fracture site. So not much displaced actually. Even it was just only thing is it was like 15 months was one criteria. I did not have the courage to just put a screw, because a lot of literature says within 1 year. But this chap, I wanted to put this thing because the profile here looked okay, but here he had a lot of sclerosis at the fracture site. So we did this at arthroscopic. This is what is the fracture non-union site, which we assess this is the non-union site. I'm probing that area. That's a fibrous tissue at the non-union site, which I'm trying to pull out. So basically I use a shaver, clear up all the non-union site until I see cancellous or the bones on either end. So it's a mixture of both the shaver and the curette I use. So this is how the after curettage, you can see this is the bone non-union site. You can see that's a distal pole. This is a distal pole. That's a proximal pole. I'm using curette. You can see I'm literally taking the scope inside that. You're seeing from above. So the proximal pole, the distal pole, and your probe is here. So and nice curettage. You can see that 1 or 2 attempts which have been made for the K-wire passage also. You can see that shows a good cancellous bone there. And now you can see the profile. That's the curve of the scaphoid. That's a waist level of the fracture side. So after this, we tend to fill that area with a lot of bone graft. I take bone graft usually from like Jain needle I use. So from the iliac crest I take rather than from the distal radius. So you get nice compacted bone there, which is already compacted and which can be passed into the recipient area. So this is how we pass through that. So this is the scope in the midcarpal portal. This is the 3-4 portal. This is the midcarpal radial, and this is how where I put the pass the bone graft through that. So at the end of the procedure, these are the portals, and this is what is the closure site. Just a couple of stitches there, minimal scar, and that is the screw in that side. 2 months follow-up. Surprisingly, the union rates are very faster compared to this because you can see visible bone formation there compared to the open method here, these things. So the advantages are you could assess a thorough adjustment of the wrist. You are basically, I'm convinced with the fact of biological environment. I'm not cutting anything here. That is what makes me, I'm more convinced with that. Hardly, I am just retaining the entire capsule of the tissues and the circulation around that and instilling only the nice cancellous graft and immobilization from that. So delayed non-union, this is a treatment algorithm what we generally follow. Delayed non-union, mini open, established waist, no deformity, open repair or autogenous or arthroscopy assisted. Humpback deformity, always volar approach and bone graft. Either you could use a combination of a cortical cancellous and a cortical strut as well, intercalated wedge. And proximal non-union pole, that is viable, usually dorsal approach, headless, open bone grafting fixation with headless screws. Avascular non-union, again, these are the options which we have tried, but nowadays, as I told, I don't strictly follow that. Any questions on that?
Do you regularly do CT in these cases? Because I found that a lot of bone resorption is there if fracture is more than 1 year old.
Yeah, I do that because it gives me two things. One thing is humpback deformity, because as I told, they would have united and still causing pain. So that is where CT is helpful. If I have doubt, if I can't see really a fracture line in that, and still patient has pain and previously documented that he had got a scaphoid fracture, I would definitely do a CT. I've not corrected a humpback deformity. I would say that it's united, but you have this. I have still not corrected a humpback deformity.
Okay. If you feel that it is united, but it is painful, and in X-ray you see some cavities, so how you will proceed now?
I have not done many of them. One case I had like this, he had some small cyst along this thing, long standing, almost 5 years. But even the union, only one side it could. I just put this thing, what is it, scopy assisted, curated that area and put few bone graft and it went on to union well.
Okay.
What
Yes.
options? Next one, next case. 25-year-old male, pain in right wrist, underwent surgery for scaphoid fixation 9 months back. Percutaneous fixation, it was done. Now has pain in right wrist, mild swelling, range of movement 80 degree, palmar flexion 80 degree, terminally painful. This is the X-ray. What are the problems? What will you guys plan for or suggest for?
I think the main problem is with the stability with regards to the screw size.
Yeah, that is one, correct. There's a lot of lysis also around this. I don't know, means around the screw. That is also was bit, I was worried about that as well, infection. But there was no clinically, there was no local signs of infection. But apart from that, yeah, definitely stability. The screws, just not screw size, these are like some of these Indian companies where the shaft thread of screws is very thick. And these are not generally 2.4, they might be a little bit more thicker, 2.8 or 3 mm, something like that. So these can be quite problematic in our population, I feel. Means we should be really think twice before using anything more than 2.4 mm screws. What do you suggest now? What to do now?
Yes, so I can see that there is some rounding of the edges also.
Hmm.
I'd rather remove the implant, curate the bone ends well, put in a bone graft. I mean, I'll do open. And I'd maybe prefer K-wires in this because already the canal is hollowed out because of the previous screw.
Hmm.
So to be on the safer side, maybe I'll go for K-wires only.
Any other opinion? Any other options?
Removal of the hardware.
Yes,
I
sir.
think arthroscopically assisted, if you can see there is no, you can rule out infection. And if there are not lot many cysts, I think graft can be placed, and again a larger size screw, like longer. I mean, not a larger one, a lengthier screw.
Lengthier one. Yes,
lengthier screw, if it can hold on to the ends well, I think that would be more stable fixation, as the history is almost non-Indian. Now, without a screw and holding on or believing on only KYS for a longer period won't be a good idea, because then immobilization will increase. Period of immobilization. So I think a longer screw, removal of the hardware, put in a graft, and then check the stability under scope, and then limited immobilization, and then your restoration of the physiotherapy and restoration of the ROM.
Yes. Anything else, Amit?
I'm expecting means screw removal may be difficult.
Why? Why do you feel so?
Either we have to remove from the fracture site, or luckily means we may get entry point, then it may be okay. And then infection may be troublesome, but I will do open only, and lot of bone graft and K-wire.
Okay. Okay. So looking at this, there are another few more points which I thought lucency was there. This screw is short. So that actually one good thing in favor of, means that helped me to treat, because I still have so much of bone for my screw to engage. If it were to be longer one, definitely I would have also used a K-wire. I thought, okay, this can be managed with a screw because he has quite a significant amount of pole still left behind here. And I also decided to do an open only itself, because of this lucency, I did not try too much to open on this side, because I'll lose the distal pole. I opened the fracture site, it opened up easily, then I got it out from the fracture site, the implant. So that reduced my chance of damaging the distal pole, or else I would have damaged that, then none of the screws will hold. So small tips, but I think that was helpful to revision surgery. So just when I again saw this was one of the earliest revision surgeries I was doing. I was quite keen. How many cases these things? What is the percentage of this thing second surgery for non-union? It's almost 8 to 10%. Again, it's a Western literature. We don't know here. It might be even more. What to do with that? Options are osteosynthesis or salvage. As I told, I opened it. I took out the screw from the non-union, and in that X-ray also there was a lot of loss of height as one thing. I will just show you this thing. You can see the lunate is almost gone into disc deformity, and this is really humpback type. You can see here also, you can see the dorsal rim of the lunate till here. So that I had to restore that as well. So that means I need distraction and a lot of bone graft. Opened it here, restored again. Now I got the lunate well aligned and the good lengthy screw. Bone graft, I used distal radius itself, that I could manage it. That was quite good finally. Went on to almost 3 months follow-up. went on to good union. So this is what is a paper on the revision surgeries, like non-vascularized, non-unions repair. So they did this after vascularized or non-vascularized repair. It's almost, they're telling now the union status of the revision status is almost 8 to 10%. So they did the study, 4,000 patients they did, and vascularized. Out of that, 358 vascularized, 3,000 non-vascularized. Failure rate of vascularized was 5%, non-vascularized 6.1%, not much of a difference. Of course, age and comorbidities did not affect the bone type. So these were some of the cases or different varieties of this thing, which I could discuss. You want anything else more on that? Any
Dr. Amit, if
suggestions?
we could have that video, I think the second case, in case you have time.
Which one? The vascular arthroscopic?
Arthroscopic. Yeah,
Sure,
yeah.
I will show you. Yes, sir,
I
right
think
away.
that would be a good idea to see a nice thing.
Right away. I'll show you. We do a lot of arthroscopy assisted procedures, sir. Even distal radius malunions, TFCC repairs, lot of procedures we are doing under arthroscopy guidance. Even partial wrist fusions, if you want, I can show. Then like delayed presentation, radioscaphoid, radio capitate, radiolunate fusions, arthroscopic, just when percutaneous fixation. So typically this procedures entails, this is a non-union site. So these are the portals what we use. So assume the wrist as a two-floory building. This is a ground floor, this is the first floor. So you can see the wrist in this floor for a lot of TFCC work, but when you want to assess the scaphoid non-union site, you want to do the mid-carpal. This is called the mid-carpal joint. So we have to go to the first floor to assess that. So this is the portals, that is the mid-carpal radial portal, and these are the accessory STT portal, that is scapho, trapezial, trapezoid portal. So I visualize through this and I put all the grafts through this portal. So these are two other portals which are workhorse for this procedure. It is on vertical traction on tower what we use, and finally fill the bone graft. And so this is what is the case what I was discussing. So you can hardly see here, whereas in lateral view and the oblique views you could see some sclerosis on this. You can see this was a non-union site. So you could use various types of traction. This is one of the easily available traction board which we use. So basically assessment of this is the non-union site which I am looking into through the mid-carpal portal. So I use a needle there, try to assess that. Clear all the debris through that. So I use a combination, as I told, of both curettes and shaver. So this is the burr also I'm using just to impression, but nowadays I don't use much of the burr. It's mainly shaver and the curette which helps us to clear all this. So you can see the two ends of the scaphoid non-union. Once you see that, to clear it, and always try to, you can take some bone grafts. This was what one of the other bone varieties. You can take a small bone graft, chisel it, or you could take a Jain needle. And this is the radiocarpal joint. So don't try to push the bone graft into it, or else it will go to the radiocarpal joint. So because this bone graft will sink from mid-carpal to bone graft. Don't try to stuff it in too much. try to leave a scaffold or a thin fibrous tissue on the other side and try to. So once you pack it with like nicely with a bone graft like this, you could use a tissue glue if you can. Initially I used to use, nowadays I don't even use that. So that is just holding on, and then I put a percutaneous screw. So this is a nicely well packed bone graft at the non-union side. This is the tissue glue which I'm introducing into that. So once I introduce that, I take it out of the traction, then put the percutaneous screw. So once I fix that with the percutaneous screw, then again I check the radiocarpal if some bone grafts have fallen in. There was some amount of bone graft. This is in the radiocarpal joint which has sunken there. So I shave it and take it out. So this is the end of the procedure. After the procedure, this is how the scar will be. And that's the range of movement you can see, or the good fixation means either you can see the bone graft here, nice bone formation. This is at the end of 6 weeks. That is what is the beauty of this arthroscopic fixation. You can see nice bone formation there. You don't have a doubt on the bone formation.
Nice, quite a good one, huh?
Thank you.
This is something newer technique, and absolutely all. I think all our newer or younger colleagues should see the advancement going on pan India. I think we not look at international faculty to see all these arthroscopic assisted fixations.
We have a lot of even distal radius fracture fixation and these things maybe sometime, because we are doing almost from past maybe 2014 we started. Initial 2 years was quite bad. The frustration was levels were very high. The scope used to always pop out of the wrist and used to blame the assistant for not holding the scope properly. Now you got the hang of it. So we're doing almost a lot of procedures with this thing. Like every month at least we are able to now do more than 8 to 10 wrist arthroscopy alone. Various procedures, and that means different varieties.
What angle scope we use in this?
This is 30 degree only, sir.
30 degree only?
Yeah, 30 degree. You have the other scope is available, but that's expensive. Like what you guys, even the Arthrex guys are selling it right to 0 degree scope for everywhere, that needle scopy 1.8.
Okay.
That's quite expensive. This is good, 2.4 mm.
This is 2.4 mm?
Yes, sir. I use 2.4.
1.8 would be very costly.
1.8 more than costly, very difficult to handle.
Very costly.
It'll break very. This itself
It breaks
people
very thin.
In the course, every time I conduct at least 2 scopes, they break. The same time the company guys say, "This is the last course. Wapas nahi karenge, bas ho gaya." But luckily they have been supporting so far.
Darshan, how you manage the traction as well as the C-arm, means while doing arthroscopy?
This scaphoid fracture which I did, I fix. I do all the scopy all together, then take it out of the traction, then I fix it percutaneously. So it is not in same go.
Okay.
It is traction is out. If at all, yes, there are some situations where I may have to use, then I have to bring it like this. The C-arm is like this. The hand will be like this, and the C-arm is, you put this thing, sterile sheets on either side, then I check. And actually it is easy to check, because once you go up, you can twist your traction board also. You can take rotations there. You keep C-arm static and you twist the hand. You can take all the obliques lateral there itself.
Just to complete the discussion, if suppose your scaphoid has not united for 10 years or something. So basically I want to ask what is the management of snack wrist in your practice?
Snack wrist, grade 1, just grade 1 or 2 styloidectomy you can do, styloidectomy you can do, and pin or the neurectomies also, denervation procedures you can do. When it advances beyond that, then I do either scaphoid excision or scaphocapitate fusion, proximal pole excision, because if it is non-union, excise that proximal pole and scapho capitate or capitolunate fusion also can be done. If it's young chap, and always try to combine with the denervation procedure. I've tried few cases with these graft insertion, whereas like use a tendon graft interposition where the scaphoid fossa is bad. It's less painful, but it's not so there's no advantage of the movement per se, where we interpose the tendon graft as a sandwich there between the two articular surfaces. Not many, but it's quite time-consuming procedure, I felt, and really did not make much of a difference.
Okay, we have few minutes left, so I will discuss one case.
Yeah. Sure. I'll stop sharing.
Are you able to see my screen?
Yeah.
Yes.
Yes.
Basically, this 45-year-old right-handed army man, he had wrist injury, probably scaphoid fracture, which was treated by operative procedure. But after 6 months, he has persistent pain. And in each and every activity, especially when he's touching his volar aspect of wrist, especially he says that when he applies hair in the oil, it is also painful. In the range of movement, dorsiflexion, palmar flexion, and ulnar deviations are okay, but there is restricted radial deviation. And these are the clinical pictures. And this is the radiograph. Darshan, how you will go for this course?
These type of this scaphoid is totally subluxed. Even the lunate, I don't know whether it is in the this thing, because this view is not telling me accurately. If you have a CT scan at least, or a further imaging, so that two things I want to know with the MRI and CT, whether what is the status of the capitolunate and what is the status of the lunate also. If that is there, so that this scaphoid, I will not try to save it, or I will not try to put it back inside if it has stayed so long outside. I would rather try to salvage this, because he's also must be having some sort of arthritis on this side. So if you have further imaging, anything, MRI or CT, anything you have in this?
No, I'm not having.
He's 45 years, correct?
Yeah.
Amit,
yeah. Yes, sir.
I think this was a case of scaphoid, some perilenar dislocation. Since the lunate is dislocated and the scaphoid is totally dislocated.
Yes.
So probably this was dislocated from the day one.
Yes.
And they have fixed it up.
And surprisingly, scaphoid is united also.
not united.
Not united. Huh? Okay. In this view, it's something. Okay. So two options. Either means if the lunate, if the capitate, this part is there, I would rather, if the proximal pole of capitate is good, I may. Do you have any images, or that's only?
Yeah, that's only.
That's all. Okay. So if this is the only image, I don't know whether the capitate is also arthritic pole here, the proximal pole of the capitate. If it is arthritic, then I may have to consider this capitolunate fusion, or else if it is not, then I can do a proximal row carpectomy or even a interposition arthroplasty as well. Okay. proximal row carpectomy and this thing, because this is one thing. I will not try to save this scaphoid.
Yes. So probably any other opinion? I've done the same. I tried to remove the. Yes, sir.
I'll do this excision of a scaphoid, proximal row, and then the fusion of capitate unit.
Capital unit. Yes. So remove the screw, and I saw that capitate was sitting in the lunate, and the whole the scaphoid, no, it was somewhat frail, so it came out. I removed the scaphoid, and then did the capito lunate fusion.
Okay. Looks good. But why did you use a capitate radio lunate wire? Why did you use that?
Just to maintain the normal alignment of the lunate.
Okay. So usually these type of issues, if at all instabilities arises, it is usually the radioscaphocapitate ligament issue. That's where whenever we want to remove a scaphoid on the through volar approach, and doing PRC through the same approach is very risky business. Because we will be invariably, when we want to take out the scaphoid, there will be a damage to radioscaphocapitate ligament, RSC ligament, or else we may have to repair that also.
Yes. But
good alignment is there with the lunate alignment is good. It looks good.
What was your approach in this case? You did the volar scaphoid. You approached the scaphoid through the volar, and then you did this.
Because the screw head was on the volar side, so I removed the screw from the volar side. Then did the fixation from the dorsal side, fusion and fixation from the dorsal side.
So this is the intraoperative picture, and then
later on I removed this radiolunate wire, and then after 6 weeks of immobilization, I started range of movement exercises with a splint. Then gradually this united, and he is having reasonable range of movement.
Yeah, that's good range actually for the kind of injury.
And I'm not having the picture, but when one of this wire was broken, and then I removed the distal parts, and still he is having good range of movement.
Okay.
Any lateral view of this?
Which one, sir?
This
one.
This is still the oblique.
Not true.
Yeah, this one.
It is slightly dorsiflex, otherwise it is lateral.
Have you removed all the hardware, or do you have still any?
The
broken piece.
The broken piece.
Okay. Quite good range of motion is quite good.
Good.
And he is doing basically he is driver.
Okay.
I mean, so he's doing all the work.
Yeah. Good.
He must be a happy man now. Quite good.
Another thing, what I want to discuss. Another 25-year-old right-handed male presented with wrist pain on activities of daily life. He had trauma 6 months ago when his left wrist was suddenly loaded when he tried to save fall off his motorcycle. That time he was treated as a wrist sprain with crep support and something. Then now it is 6 months. And X-ray was showing a scaphoid fracture. When I went for CT, you can see this is scaphoid non-union with gap formation.
Yeah.
And in few of views, you can see some cyst formation is also there and some bone loss is there.
Yeah.
These are the other sections. And these vital sections. So, Darshan, any other information you want?
His DRUJ is okay, is it? Put up the previous slides. His DRUJ, the distal radial have joint seems to be dorsally subluxed. The transverse sections, go back. Go back. Yeah.
This one.
This one, you can see that. Because the second row, all of them looks it's dorsally subluxed. I don't know whether it has supination, pronation. How is it?
No, probably I have not seen because his main problem was that side, but he has never complained.
Okay, then must be good. Okay.
Maybe.
His X-rays is this thing you have?
Oh, I'm having previous X-ray.
X-ray you have pre-op? This one?
No,
X-ray, only CT.
Yeah.
Yeah, this one actually it shows a humpback deformity as well. So you can do open bone grafting volar approach because there's a lot of you need to open up the size because lateral cuts. No, the next view you can see. Yeah, you can see there's a humpback deformity and the irregularity there. So volar approach, bone grafting and screw fixation. Distal radius bone graft only is sufficient.
So which type of graft do you use?
This one, because it's just 6 months, distal radius is sufficient from there itself. I can use you can combine with one single cortical strut, you can leave it inside and fill the surrounding area with cancellous bone and put a screw.
Any other opinion? Dr. Garg or Jasawant Aviral?
As we'll do open reduction. I think a vascularized graft would be a better idea here. 6 months is a long period and humpback deformity. I think MRI also.
Proximal pole was okay, and there was cavity.
Distal pole
is there.
Distal pole cavitation is there. Huh?
Yeah. So I preferred non-vascularized graft only.
Non-vascularized? Okay.
And use 2 K wires to fix because I'm doing what I'm making the holes in the like Matirus technique proximally and distally, and then using the strut graft.
Yeah, the strut graft is quite good actually.
And nowadays I'm using the distal and radius. Previously I was using iliac crest bone graft.
If at all you want to use strut grafts, actually olecranon is much better than even distal radius. They're much more harder.
Okay.
the volar rim, or the volar side of the distal radius is thin, whereas the ulnar border of this olecranon is really thick.
So what I'm doing that I'm using that hybrid materials, the vertical part from the distal radius, then cancellous part, as you told.
Yeah, it's good.
So at 3 months, it started showing union, and then later on, it united well. And
did you do anything for the radial styloid? It looks like he has some issues on the radial styloid. Yeah.
Yes, good point you raised.
Can we nibble this?
Yeah, better.
To increase the range of motion.
The movement might not now, but it will go into arthritis fast.
Arthritic, because it is going into arthritis now.
Because for some reason, always they also have that excess bone formation on that radial side of the scaphoid only, and that rubs there.
Maybe because some irregularities, are you able to see?
Yeah. No, and that quite often it happens actually when we put that side little bit of bone graft, somehow it sneaks there and that irregularity forms.
And one thing I want to ask for the technical help. See, you can see the C-arm images. It's often I found this problem when you fix the your scaphoid. Unit is tilting dorsally. Is some length problem or it's okay? Because later on it settles. Don't know.
No, I almost always use this thing that I have made, because even I had all these issues. Then I don't know whether scaphoid is flexed, extended. So always put either stabilize the proximal pole, either put a wire to proximal pole or lunate.
Okay.
And to the radius. So you hold that. Without holding them, whatever we do, I feel it's going to take more time to get the good reduction or good alignment as well.
Okay, you fix.
Always put that radial lunate or radius to proximal pole scaphoid one wire. It's easy.
Yes, good tip. Although he had reasonable range of movements. And,
yeah, looks good.
So when significant bone loss is there, I use this Matty-Rossi technique.
Okay.
So probably we have finished our webinar. So I will hand over to Dr. Jasawant Singh, sir.
Yes.
Yes.
Thank you very much, Dr. Darshan,
Thank
Amit,
you, sir.
Rahul, Surendra, and Aviral, and all the other members. Rahul, especially Rahul Katta, who has organized this webinar in last couple of years. And especially I'm thankful to Amit Vyas. He is the key person who is managing all the things, especially in the field of hand surgery. And I must also thank Dr. Darshan, who has spent so much time and making our evening full of knowledge and education, rather packing the evening with the knowledge.
Thank you very much, sir. It was a pleasure.
And in fact, after having experience of more than so many years, every time on the topic of scaphoid, we learn so many new things.
Yes, sir.
And for this, the early diagnosis of the scaphoid is key. And there has always been a debate to get the CT scan or MRI. And most of the time, we are confused when to get the CT scan, when to get the MRI. But the MRI gives you some information, but that doesn't dictate the terms, dictate your treatment. For the early diagnosis of a fracture, when you have high suspicion, the MRI could help you. When you have the issues of vascularity, then definitely the MRI would help you. But when you want to find the cavitation, fracture pattern, and the bone matrix, then for any planning, you need a CT scan. And to get the good and stability during the intraoperative period, this is a new technique which we were not frequently using that the fixation of a lunate can help you while doing the percutaneous spinning. So with this, and probably after getting so many case studies, most of the time you can come out with the cancellous bone graft, cancellous or cortical bone grafts when there is a large gap. And now the vascular graft, if I'm not wrong, vascularized graft is not that much practice now. And you can, most of the time, 99% or 90% of the cases, you can come out with the cancellous bone graft, strut, or some grafts. So with this, I must hand over the mic to Dr. Amit, and thank you very much, all of you who has participated in this meeting, and to the whole of the Rajasthan Orthopedic Surgeons Association also, because of their motivation, we are getting the things done, and we are involved in this academic activity. Thank you. Amit?
Yes, Dr. Rahul Garg, would you like to conclude?
Good evening, and I think Dr. Darshan has enlightened us too good to see such a good work done in India at national level, and so many new things which all our younger colleagues can appreciate and can, in fact, those people who are interested in hand surgery, they will be benefited, as well as all our younger colleagues who are into general practice are now very clear with what to order at what time and how the algorithm is set. I would definitely thank Dr. Darshan and Dr. Amit Vyas, is dynamic hand surgeon in Rajasthan, who is taking care of academics to bring the academics at very high level. Thank you very much for sparing your time. And thank you, ROSA, for giving this a platform. Thank you, OrthoTV, for providing us to stream this online. And we will be coming out with number of views, I think, by tomorrow. I think this will go on. I think this is most sought after webinar going on since last almost 3 years now. Thank you, Amit, and thank you, madam, for continuing to do so. And thank you, colleagues. I think Amit can take over and say good night to everybody.
Thank you all.
Thank you. Thank you very much. Thanks.
Thank you. Good night. Good night. Thank you, ma'am.
Thank
you. Okay, we are.